Capturing how patients actually feel, their symptoms, their function, their quality of life, is one of the most important and most tedious parts of clinical research. Patient-reported outcome measures are the standardized questionnaires that do this, and developing one can take years. So here's the question: can large language models speed that up without breaking the science? A commentary in the Journal of Patient-Reported Outcomes says yes, but only with humans firmly in the loop. Patient-reported outcome measures, or PROs, are standardized questionnaires that capture how patients experience their symptoms, function, and quality of life. Developing a PRO takes years of qualitative interviews, item drafting, cognitive testing, and psychometric validation, testing whether the questionnaire actually measures what it claims to measure. The question this commentary addresses: can large language models safely accelerate any of these steps without sacrificing validity? The authors identify 5 bounded use cases. Domain cartography, mapping out the different aspects of a health condition from existing research. Item generation, drafting large candidate banks for expert review. Cognitive interview support, simulating patient interviews to spot confusing wording. Semantic coherence checks, catching duplicate or unclear items across the full set. And developmental adaptation, adapting measures across languages and populations. Each use case is deliberately narrow. LLMs assist, never decide. But there are real risks. Confirmation bias. LLMs may reinforce existing frameworks and miss novel constructs. Semantic circularity, when AI-generated questions look right but aren't grounded in real patient experience. And construct drift, when repeated AI passes quietly shift what the questionnaire is actually measuring. These risks are subtle. They can easily pass superficial quality checks. The authors propose a human-in-the-loop roadmap. Human oversight. Domain experts validate every LLM output. Model triangulation. Use multiple LLMs and compare outputs. Bounded scope. Limit each LLM task to one specific step. And a patient anchor. Ground every item in qualitative patient data. The roadmap keeps humans as the decision-makers at every gate. Caveat: this is a commentary proposing a framework, not an empirical validation. But the core message is clear. LLMs can be useful tools in the PRO toolkit, but only with explicit guardrails, human judgment, and patient grounding. If this kind of translation is useful to you, take a second to like and subscribe. It really does help. And catch Healthcare AI weekly every Friday at 9 a.m.